My name is Ikchal and I'm going to talk about pituitary tumor endocrinopathies. Definition. Most tumors of the pituitary and supraciliar region are pituitary adenomas. Rarely, pituitary tumors are carcinomas. It's a disease that is produced by a tumor in the supraciliar zone most of the time and produce different symptoms associated to endocrinopathies. Application in medicine. Surgical excision when is possible. For endocrinopathies, drug treatment. Pituitary tumors that produce ACTH growth hormone or thyroid stimulating hormone are surgically excised, usually using a transsphenoidal approach. Sometimes, particularly for surgically inaccessible or multifocal tumors, radiation therapy is required. Note: non-secreting adenomas may be unrecognized for years and are usually diagnosed because of local Moss effects or hypogonadism, or are detected incidentally. Chiasmal compression causes gradual progressive deficit in vision, and about two-thirds of patients have decreased gonadotropin levels and hypogonadism. Pros and cons. The pros and cons of treatment are complete resection of a non-secreting macroadenoma is achieved in approximately 65% of patients, with visual function restored in up to 80% of the patients and hypopituitarism. When present, reserved in approximately 50%. Preoperative tumor invasiveness largely determines the risk of postoperative, persistent or recurrent tumor requiring adjunctive irradiation and reoperation. Radiosurgery was associated with high rates of tumor control in a multicenter analysis involving 512 patients followed for a median of 36 months, and pituitary failure developed in 21% of the patients. In a retrospective analysis of tumor growth rates among 237 patients who were followed for a median of 5 or 9 years, 36% of the patients had a recurrency after surgery alone, whereas 30% 13% had a recurrence after surgery and adjuvant radiotherapy. Issue apply in Ecuador. Pituitary adenomas are frequent lesions representing approximately 10% of all primary intracranial neoplasm. They constitute the third neoplasm in order of frequency of all primary intracranial neoplasm, behind gliomas and meningiomas. The incidence by age and sex varies according to the type of tumor. In general, pituitary adenomas are adult tumors; less than 10% occurs in children. After a search on the web, it is found that no cases of this disease have been reported in Ecuador so far. Conclusion: pituitary adenomas account for approximately 15% of intracranial tumors. Management Management of these benign tumors requires diagnostics of the specific intracellular disease and comprehensive multidisciplinary treatment of local mass effects and peripheral endocrinopathies. Since tumors can produce different hormones, their consequence and management vary widely. Now you can see some videos about this topic.
Dennis is a family practitioner from Missouri, and he had noted about 4 or 5 months of progressive fatigue, cold intolerance, decreased libido, just not feeling well.
And I went to my doctor and we did a blood test and found out that I was very low in testosterone.
But then he also noted his vision continued to deteriorate, and he was subsequently diagnosed with loss of his peripheral vision on some formal visual testing.
4 months ago, I was noticing visual blurring in my left eye. After going to several eye doctors, I had visual fields done. And they showed an abnormality in the superior temporal visual field bilaterally. And that's pretty indicative of a problem in the pituitary area.
He then went on to have an MRI, which showed a relatively large pituitary tumor, causing a severe compression of his normal pituitary gland and his optic nerves.
As a physician, I have access to the medical library, and I read up as much as I could on pituitary adenomas and tried to find surgeons who excel in that type of surgery. That is what led me to come here with Dr. Kelly.
This was removed through an endonasal endoscopic approach with my colleague, Dr. Griffiths. We were able to achieve a complete tumor removal.
My surgery lasted between 4 to 5 hours. I woke up in the recovery room. I was in the hospital for only 2 days. During that time, I felt amazingly good for having had essentially brain surgery.
And within a few days of surgery, his vision had improved markedly, and he was feeling much better on appropriate hormone replacement therapy.
My experience here at St. John's is just excellent. It surpassed all my initial expectations. The doctors that have been involved in my care, the hospital, just been super.
He's done very well. He went back to Missouri about 10 days after the surgery.
Now another video.
I love running, and I always did, and all of a sudden it became really, really hard to run 1 mile. I went to my physician for an annual checkup. He decided to run a special check that he doesn't usually do every year. And when the results came back, he said, "You don't have any hormones in your body. It's absolutely zero." And he said that could be an indication of only one thing. It's probably something in the head. He said maybe it's the pituitary gland, but I'm not sure. Why don't you do an MRI? When the MRI results came back, he called me and he said, "Listen, it's bad. It's not only do you have a tumor," he said, "what you have in centimeters I've never seen in my life as a doctor in millimeters."
TSH secreting tumors are very rare. They represent less than 1% of all pituitary tumors. And usually, when a patient has a damage to the pituitary gland no longer stimulates the thyroid to make thyroid hormones if the tumor is large. In his case, his thyroid hormone level was elevated, but his TSH level, which is normally low in patients who have overactive thyroid, was actually elevated. So the two tests didn't quite make sense with each other, except by the possibility of him having this very rare form of pituitary tumor.
One of the things that I discovered when I went to Johns Hopkins was that I was losing sight on my left eye, and I didn't even know that. I was losing the peripheral vision on my left eye.
Because he had compression of his optic nerves, he had already some vision damage, and therefore we couldn't wait for a medication to try to shrink the tumor, but we had to act fast to decompress his optic nerve and recover his vision.
Finding out that you have a brain tumor is horrible. Is a horrible moment. You feel like your life collapsed, and you feel like it's the end, but it's not. The recovery was very speedy, was very, very quick. After 2 weeks, I was already working, went back to running. I'm training again, I'm running again. I think that in the whole scope of being extremely unlucky and getting a brain tumor, I was 100% lucky. I was lucky with the people around me, and I was lucky with the team at Johns Hopkins, and I was lucky to be able to get my life back. Hi there. I'm Dr. Gary Simmons from Carilion Clinic Neurosurgery, and I want to talk to you a little bit about recovering from pituitary tumor surgery. We talked about pituitary tumors and the type of surgeries that are involved. The grand majority are done through the nose, and there is some recovery involved in this, and I want you to know a little bit about it. When we do that type of surgery, of course, we have to move things around in the nose, and afterwards, there's often stents or packing that's in the nose, and this will feel like the nose is terribly blocked up. Usually, all that sort of thing comes out within a day or so, and so it's not there for very long. But for a day or so, you have to breathe through your mouth predominantly, and that's an odd feeling. Once that has occurred, your nose can be a bit runny and there can be some bloody discharge, but that will stop and it won't be a big problem. You also might feel a little bit of bloody discharge down the back of your throat, and that will settle down as well. One of the biggest concerns and one of the things that we watch for in particular after the surgery is how much you pee. Now, this may seem odd, but there is a hormone from the pituitary gland that regulates how much you pee. And it's very important for how much you pee to be regulated, because too much and you become very dehydrated. Too little and fluid backs up within your body. So it's very important for that hormone to be working well. And it's not uncommon at all for that hormone not to be working well and that you end up peeing way too much. That has to be followed so that you don't get too dehydrated. If you are having problems with peeing too much, usually you can keep up with that by drinking. The problem is that could end up gallons a day. And so there are medicines that can be taken that will regulate how much you pee. Now, often the hormone will come back to normal after a few days or after a week or so. So we watch that over an extended period of time. And we often watch that with the help of an endocrinologist. That's a doctor whose specialty is hormones and hormone production. Finally, there's another issue that can occur with some frequency, and that is something called a spinal fluid leak. The brain is housed in a bag, and in that bag is very clear fluid called cerebral spinal fluid, or CSF. And the pituitary gland hangs just below this. If it's a big pituitary tumor, it can stretch that bag so that when we remove the tumor, the bag leaks. And cerebral spinal fluid, or CSF, loves to leak. It looks like spring water and can get through the tiniest of holes. So we have to patch that up, and we watch for this leak for several days after surgery. If there is a leak, we may even have to put a drain in your back to help take the pressure off of the leak, or very rarely go back into surgery and re-repair where the leak is coming from. The good news is we'll always get rid of the leak. But the bad news is it has to be dealt with, because if it can leak, that means bacteria can leak inside into the head and cause an infection around the brain. So controlling the leak is very important and will be watched very closely. Thank you very much. Bye-bye now.
If you've been diagnosed with a pituitary adenoma or related tumor that may require surgery, this brief video describes the latest minimally invasive techniques our surgical team uses to achieve safe and effective tumor removal while promoting a rapid and more complete recovery. Endonasal endoscopic surgery uses the nostrils as natural corridors to remove pituitary adenomas and other midline skull base and brain tumors. This minimally invasive approach involves two surgeons working together using a high-definition endoscope and refined low-profile instrumentation. To reach the skull base and pituitary, mucosal incisions are made in the back of the nasal cavity that aim to preserve the blood supply to the mucosa and the sense of smell. The mucosa is elevated from the back of the nasal septum and sphenoid bone. The natural openings of the sphenoid are then widened and connected, creating a corridor to the skull base and pituitary. This allows the surgeon to maneuver two instruments within the sphenoid sinus while being illuminated and visualized by the endoscope. Next, the bone of the skull base over the tumor and pituitary gland is removed. Prior to opening the dura, which covers the pituitary gland and tumor, the Doppler probe is used to precisely localize the carotid arteries. The dura is then opened and lifted upward, revealing the pituitary tumor and compressed gland. For large tumors, such as the one shown here, the lower portion is removed first using microinstruments and suction. The remaining tumor is separated from the surrounding normal structures, most importantly, the compressed pituitary gland, to help preserve or restore its function. The entire cavity, including the walls of the cavernous sinus, is then carefully explored with angled endoscopes to make certain that all safely accessible tumor has been removed. Following removal, the tumor cavity and bony opening are typically covered with a small piece of harvested fat and bone, which are held in position with collagen matrix and tissue glue. The endonasal approach is also used for many midline skull base and brain tumors, such as meningiomas. Craniopharyngiomas, and clival chordomas. In such cases, more extensive skull base exposure and closure is usually required, including use of specialized vascular flaps to help prevent postoperative spinal fluid leaks. After endonasal endoscopic pituitary surgery, on average, most patients are out of the hospital within 48 hours and back to full activity within 2 to 3 weeks. For more information, visit us at www.brain-tumor.org or call 310-582-7450.
So fertility out of pituitary gland is the first step in a tumor's hormone annealing in this area. You have to remember the pituitary gland measures about the size of a kidney bean and sits right at the base of the brain, right above the earlobes, right in the middle of the head. And it controls all the hormones in our body. And that's why we call this the master gland. And as lesions, whether it be a tumor or a cyst, grow within the pituitary gland, I kind of break it down to three problems it can cause. The tumor itself, because it arose out of the pituitary gland, can actually make one of the hormones the gland makes. And these are called secreting tumors. They can cause syndromes like hyperprolactin levels. They can cause Cushing's disease or acromegaly. However, later in life, the majority of these tumors do not make any hormones. So then as the tumor grows, the second thing that happens is the gland gets compressed. Two things can't live in the same space. And so whereas the average tumor size may be the size of a walnut or a golf ball, you can imagine taking a golf ball and squeezing it into a kidney bean. What happens over time is the gland gets compressed. And as you slowly squeeze the gland, the hormones the gland makes slowly shut down. Typically, the first hormone that's lost is growth hormone, hence why in kids, short stature is one of the most common symptoms that develop. However, after puberty, we don't grow any taller. And so even though most adults will lose growth hormone, they'll be asymptomatic. The next hormone that shuts down are the sex hormones. So in women, it causes premature menopause. That's why oftentimes we catch these tumors when they're smaller. In men, the same thing happens, but they lose their testosterone. And unfortunately, as is most of the case, we kind of write this off and saying I'm getting older, or that's not oftentimes picked up. The third hormone that shuts down is thyroid, but we really need a large tumor and a loss of a lot of gland before we lose that hormone. And the last hormone to shut down is cortisol, which is a steroid hormone. Now, thyroid and cortisol are both hormones of metabolism, and so it makes sense that the last two hormones your body is willing to give up. But all these hormones have to be evaluated in all patients before we consider any treatment. And the last thing we worry about is that the tumor outgrows the cavity, which is called the cella turcica, that it sits in. And so it starts pushing on other structures, the most important of which are the optic nerves. Right above the pituitary gland are the nerves that go from the eyes back to the brain, carrying all the visual information. And as these tumors grow, they can slowly stretch those nerves and cause progressive vision loss. Now, the body is pretty adaptive. Since these tumors grow slowly, there are some patients who will lose up to 50% of their vision and still not realize it. Eventually, once it starts affecting central vision, people start noticing vision loss, and that's when we oftentimes diagnose these tumors. But by that point, the tumors are already quite large.
Thanks for your attention.